Great. Hi, everyone. So I'm Ellie. I'm a clinical oncologist at Guy's Cancer Centre at King's College London. It's really great to be here and see everyone in person after the pandemic and not being able to travel. So I've been asked to talk a little bit about risk factors and treatment. So I'm going to focus mainly on risk factors, a bit about clinical diagnosis, a bit about surgery and radiotherapy, and then I'll hand over to Otto, who's going to talk about systemic therapy. So the first risk factor that I'd like to talk about is lobular carcinoma in situ. So I don't think that's been mentioned yet so far today. It's typically found incidentally on biopsy. It's completely asymptomatic, but we're finding more of it now that we do more biopsies through the breast cancer screening program. And it does have a reasonably high rate of developing invasive breast cancer, so 26% at 15 years, and most of those will be lobular. They won't all be lobular, but most of them will be. The reason that it's important to know about LCIS is that we can actually treat with chemoprevention, so that's giving 5 years of tamoxifen or an aromatase inhibitor. People haven't been so keen to do that because of the side effects, but there's now trials looking at just using low-dose tamoxifen, so 5 milligrams, which has much less side effects and still seems to be effective. The little picture over, how do I get the pointer to work? Is the pointer working? No. Okay. Huh? It was there. I just was pointing it in a mild wrong direction. Oh, yes. Okay. It's just that I'm doing too many things at the same time. Right. Okay. So this is basically LCIS surrounding invasive lobular. And the reason I just put this up was that we've just done some copy number analysis. And as well as being a risk factor, you can see that the LCIS is also a precursor because you see these nice amplifications on chromosome 11 and 17 in both the invasive and the LCIS. So next risk factors to talk about are the endogenous estrogens. So when you, as we've talked about already, invasive lobular cancers are generally ER positive. And so if you compare them to NST cancers, you'll always see that they're more strongly associated with hormonal risk factors, which is why it's really important when you look at these reproductive factors that you're actually comparing ILC to ER positive no special type rather than just all no special type tumours. And when you do that, we see that younger age at menarche, late age at menopause, no or few pregnancies, and increasing age at first birth, all associated with an increased risk of ER positive breast cancer, whether that be lobular or ductal. But what we do see is that younger age at menarche and increasing age at first birth are particularly associated with lobular breast cancer. If you look now at exogenous estrogen, so HRT, we see a similar thing where the risk is very much associated with invasive lobular cancer, some risk with NST. But in contrast with oral contraceptives, we actually see not such a high risk, and there doesn't seem to be any difference between the lobulars and the NST group. In vitro fertilization, the hormones associated with that, there's sort of mixed data on that. So some older data saying there's no increased risk of breast cancer, others saying that there is, and then a very small sort of one-center study saying there's an increased association with lobular breast cancer. So this slide is just taking a closer look at the HRT risk, and it's comparing to women that have never taken HRT. And you can see that the things that are important is what type of HRT you take. So if you take the combined estrogen and progesterone, you have a higher risk, and also how long you take it. So you can see here at the bottom this risk of over 3 times the never users if you take the combined estrogen and progesterone hormone receptor, hormone replacement therapy. And you can see that that risk is much higher than the risk that you get with ER positive NST, but there is also a risk for ER positive NST as well. The positive thing to take back is that once you've stopped using it, your risk really drops back down. So one of the things that we've noticed in the 90s was this big increase in invasive lobular cancer in postmenopausal women. We didn't see it in premenopausal women. Oops. And we think that is related to hormone replacement therapy use, because we see it really dropping off once the Women's Health Initiative showed that HRT wasn't as beneficial as people thought it was. So other lifestyle factors, obesity is a risk factor if you're postmenopausal for all ER-positive breast cancers. Alcohol, on the other hand, seems to be very much associated with invasive lobular cancer, and the study's showing that alcohol actually increases your estradiol levels. We're not entirely sure how. It may be through increased conversion of androgens to estrogens. It may be decreased rate of oxidation of estradiol to estrogen. But you can just see here, if I can get the pointer, yeah, whoops, I'm not very good at this, am I? If you're a never drinker, comparing to a never drinker, if you drink more than 7 drinks per week, your risk is nearly twice that of a non-drinker of invasive lobular cancer, much lower non-significant risk if you're for NST. So then moving on to family history. So family history is obviously a very important risk factor for all breast cancers. There was some early data suggesting lobulars might have more of a familiar effect, but actually it's very much related to lobular carcinoma in situ rather than invasive lobular cancer, where you can see that they, with LCIS, you tend to see more bilaterality and more women with a family history of breast cancer. There's no clear evidence for a higher familial risk if you compare the ER-positive invasive lobulars to the ER-positive NSTs. But the underlying cause may be different. So if we look at what are the most common germline mutations that predispose to lobular cancer, actually BRCA2 is the most common. And it's not, it doesn't just predispose to lobular breast cancer, obviously predisposes to all types of breast cancer. CHEK2, again, is also frequent and is associated with all ER-positive breast cancers, but it's the second most common germline mutation in lobular breast cancer. We also tend to see PALB2 and ATM mutations, not so frequently. The thing that's very different from NST is that we rarely see BRCA1 mutations, so they're very infrequent. They do occur occasionally, but we also see ER-negative lobulars. So, and what we found in our study of just over 1,500 women was that if you look at women under the age of 40, about 11% of them will have a germline mutation. So I think it's really important when you see women with lobular breast cancer to be thinking about sending them for genetic testing. I don't know what it's like here in the Netherlands, but certainly in the UK, genetic testing is very focused on ER-negative patients rather than ER-positive patients. The thing that is different compared to NST are these germline mutations in CDH1. So CDH1 is the gene that encodes ecadherin, which we've heard already is often lost in lobular breast cancer. And therefore, it would be logical to think that actually you'd see germline mutations in CDH1 quite frequently in invasive lobular cancer. That's not actually the case. They're quite rare, and actually CDH1 germline mutations predispose to hereditary gastric cancer. But if you look at those families, you will see that they are enriched for lobular breast cancers as well. However, if you see women who have bilateral invasive lobular cancer or bilateral LCIS, you do need to think about CDH1, because certainly in younger women with bilateral disease, the frequency is about 10%. So also really important to always take that family history, not just to think about breast and ovarian cancer, but also about gastric cancer as well. So the last bit talking about risk factors is really just a little bit about the low penetrance genetic variants and invasive lobular cancer. So there are 313 of these low penetrance variants that have now been identified that predispose to breast cancer. These variants are common in the population. They're essentially single nucleotide polymorphisms, and so the cartoon at the side there just shows that most of our genome is identical to each other's, but every so often there are some differences. So there may be 20% of people in this room with an A here, and the other 80% have a G here, and we'd call that a single nucleotide polymorphism. They tend to be located in the non-coding regions, and the ones that have been found in breast cancer tend to predispose to either all breast cancers or ER-positive breast cancers. There's only a few that have been shown to predispose to ER-negative breast cancer. And some of the work we've done has actually shown that some of these SNPs are lobular specific. So we have identified one SNP on 7q, which just predisposes to lobular breast cancer. It hardly has any effect in ductal cancer. And Ahmed, my postdoc, is going to have a poster on that later. So just trying to understand what genes it regulates. And then there's another SNP on 1p that predisposes to all breast cancer, but has a stronger association with lobular, and that seems to control Notch1 expression. So what these SNPs, what are they useful? You know, if you look at a single SNP, the risk is associated with it will be tiny, sort of 1.2 times the general population. But there's 313 of them. If you add up the total risk, then you start to get you can sort of get what we call a polygenic risk score across the population, where most people will have, going backwards, forwards. There we go. Will have average risk, but if you're unlucky enough to have inherited the risk variant, here for breast cancer, you'll be in this top 1%, and you will have this risk of 3.9 above the general population. So actually that's quite a significant risk. And then if you're lucky enough not to have got any of the risk variants, you'll have a much lower risk of getting breast cancer. And so what we hope is this type of polygenic risk score will be able to help us do more personalized screening in the future. It's not in use in clinics at the moment. So this is just a summary of the risk factors, and the ones in pink are the ones that seem to affect lobular breast cancer specifically, and I've adapted this from Karen's very nice overview paper. And I think what's really important is that we try and understand why these particular ones are associated with lobular breast cancer. It was really nice to hear that first talk about the development of the mammary gland and really try to think, why is it that some of these hormonal risk factors only predispose to lobular breast cancer? So quickly moving on to diagnosis, as we all know, it has this infiltrative pattern of growth, which means it often doesn't form a lump. It doesn't distort the breast tissue. It's very difficult to see on a mammogram and often doesn't have calcifications. And so you can't really see this very well at all, but that would be an NST, just a normal spiculate lump in the mammogram. And then for lobular, you can end up with a perfectly normal mammogram like this, but have an MRI scan that looks like this with a rather large tumor in it. So apart from mammogram, ultrasound has more sensitivity, and certainly in diagnosis, we would always use mammogram and ultrasound together, but not necessarily in screening. MRI has very good sensitivity, but the problem with that is it obviously has low specificity as well. So it's useful in that it will pick up synchronous lesions, it may size your tumor better so that you change your surgical management, but it can also overestimate, so it will also pick up things like LCIS, which maybe don't need to be surgically resected. So if you do see things on MRI, it's really important that you biopsy them to make sure that they actually are invasive disease before you change your surgical management plan. So surgery, very briefly, I think for lobular breast cancers, just because of their infiltrative nature and they're difficult to feel, they tend to have more positive margins than the no special type tumours. But that doesn't mean that these women should all go for mastectomy. If you go for a re-excision, 74% of them will then achieve clear margins. The other thing, just to briefly mention, is the axilla. So I don't know what it's like here or in the US, but we seem to spend most of our multidisciplinary meeting talking about the axilla. So the standard of care now, if you've got a normal axilla, clinically and on imaging, is just to have what we call a sentinel node biopsy. So you're basically just removing the lower nodes here rather than removing the level 1, 2, and 3 nodes. And that is great for invasive ductal cancers, not so good for lobular, because obviously it's quite difficult for them to be picked up on ultrasound. So often the sentinel node comes back positive, and then that means a second procedure. And often on the second procedure, about 30% of them will have 4 or more lymph nodes involved. As we're moving away from doing more auxiliary clearances, it means that we're actually, if we don't do them in lobulars, we're probably under-treating a few patients because we don't know how heavily node positive they really are. So I'm sure Otto might mention that in his talk as well. Radiotherapy. So there's some data suggesting that lobulars might be more radiosensitive than the NSTs, but I have to say the data is not very compelling. It's really just very old case series that have treated women without surgery and just with radiotherapy, and seen that the lobulars have got better local control. We've got quite an interesting study starting in the UK called PRADA. The preliminary data from that was published in Lancet Oncology earlier this year, and that's actually looking at using preoperative radiotherapy. So hopefully that might give us some information about the radiosensitivity of lobular breast cancer. So just, I think this is my final slide, but just to say, when we're treating with radiotherapy, our standard would be to give whole breast radiotherapy. For lower risk tumours, there's a move now to give what we call partial breast radiotherapy, but we tend not to recommend that in ILC because of the multifocality. And in fact, lobulars were often excluded from most of these studies of partial breast radiotherapy. There was one study, the Elliott trial, that did include them, but they specified that they had to be unicentric. And the one institution that's reported their use of partial breast in lobular does show that there is an increased risk of recurrence. And all the data on post-mastectomy radiation in women with large tumours, no positive tumours, so it shows that it's just as effective as it is in no special type tumours. So yeah, I think that's my last one. Over to Otto.